I'm going to turn over the meeting at this point to our colleague Matt Seidner, who will be taking over the rest of the meeting along with our president, Stephen Pearson.
All right. Wonderful. Thanks, everybody. So we'll go through a test voting question in a moment just to make sure everybody's technology is working properly. All right. All right, so here's our test question. We're looking for 13 responses. So what Los Angeles building served as the inspiration for the Disney theme park ride, The Tower of Terror? A, the Chateau Marmont Hotel, B, Los Angeles City Hall, C, the Bradbury Building, or D, Hollywood Tower. So some people who are from LA might have a little bit of an advantage on this question.
What's the answer, man?
I actually don't know.
So once you're logged into the voting system, you should see this slide on your cell phone or on your laptop, and there should be a series of options. And once you click that, it will register your vote.
Now, and I don't know.
Isn't it theme park, right? Really? Where is it? If I'm wrong.
So we are waiting for 2 more votes.
Only 2?
Has anybody not yet cast a vote? Those of you on laptops may need to scroll down in your browser to get to the voting options. We're waiting for 1 more vote. Has anyone not yet voted? Everybody thinks they voted. We're waiting for 1 more, though. Yeah, we'll just keep going. We have a panel member who'll be coming back in a moment, so we can just look at the interim votes. So the correct answer for this is actually D, the Hollywood Tower. There's a big hint in the name there. Yeah, the Bradbury Building is famous from the movie Blade Runner. Los Angeles City Hall is just a red herring, and Chateau Marmont is another hotel that looks very similar to the Tower of Terror ride. All right, well, with that, I'd like to turn things over to Steve Pearson, who will lead the moderation of the voting questions.
Thank you, Matt. Okay. Probably getting more mic than you need. Thanks for everybody for coming back after lunch. Hope you enjoyed it. All right, so we have an hour and 15 minutes, I believe, allocated to the deliberation and voting. I'd like to invite actually both Alex and Suri to rejoin. Actually, you can sit at the table here with the patients and the clinical experts, because this is an opportunity again for the panel to think carefully about the evidence, especially as it's focused into some voting questions. And we still have, obviously, the clinical experts and the patient representatives here as well. Felicia, take your time. I think hopefully you're on the voting system. Okay, good. Okay. So we have our voting questions split between chronic and episodic. And believe me, we'll return to that issue on the policy roundtable of how, if, or when that will be operationalized. But as you've heard the evidence presented, it's been kind of split between those 2 different populations, if you will. So there are going to be a variety of questions about patients with chronic migraine, and then there'll be similar questions about patients with episodic migraine. So the first question, and for this patient population, again, it's adult patients with 15 or more headache days per month, which is the classic definition of chronic migraine. The question is the evidence adequate to distinguish between the net health benefits among the CGRP inhibitors, erenumab, fremanezumab, and galcanezumab? Now, usually when I introduce the question, I turn again to the representative from the ICER team, who can just very briefly summarize what was in our report on this point, and then especially if you can point to any tables in the evidence summary handout that the panel has that come from the report to help them focus their thinking and their questions. So Alex?
Sure. So in your evidence packets, you'll see on pages 3 and 4 the inputs, so the results from the individual trials, as well as the results from the network meta-analyses. So this is for change from baseline in monthly migraine days, as well as days of acute medication use. And then the harms will be on page 11 to 12. And this includes the network meta-analysis results for all-cause discontinuations in table 3.13. And then discontinuations from adverse events in table 13.15, and the serious adverse events in 3.16.
So Alex, what was was there an ICER evidence rating assigned to this particular issue?
Yes, so we felt that because there was no direct head-to-head evidence of the existing 3 CGRP inhibitors, that we rated the evidence as insufficient at this time.
All right. Yes, Mike.
Among is, you're meaning to compare those 3 drugs?
Pardon me?
When it says
I'm sorry, could you
among-
make sure that you use your microphone so
I'm
that
sorry.
people can hear?
And among means you're meaning to compare the 3 drugs.
Correct. Is there adequate evidence to be able to distinguish among them, between them? Depends on your English teacher in high school, which one you pick. Any comments from the clinical experts on, just again, interpretations of the evidence? Again, this isn't about clinical practice yet, but anything you'd like to add about your perspective on the evidence as it exists on this particular point? Either of the clinical experts? No? Patient representatives, anything specific? Okay. Are there any questions from you all about either, again, what there is for evidence, your judgments of it? I'll ask a question while you guys are thinking. As with any comparison, can you tell us anything more, Alex, about what we know about how similar the patients were in the trials among these? Because I know the findings of them, we line up, but just remind people what we know about how similar or not the patients were in these different trials.
Sure, and just for the panel members, that's on page 3, table D1, for the baseline characteristics of the patients. And overall, again, we saw a similar distribution of age across the trials, and similar in terms of mean migraine days per month. There were differences, though, in if patients were allowed to continue using existing preventive therapies. So for fremonizumab in the chronic migraine population, they were allowed to continue, which was not the case in arenomab trials.
And any thoughts about whether these differences in trial design in terms of eligibility or the run-in phase or whatever it might be, that would have skewed results up or down compared to other CGRPs?
So it depends on if you think the effects are additive or not in terms of the CGRPs plus existing preventive therapies, or if there's a different sort of relationship between the adding on additional therapies or not.
Okay. Any questions or comments from the CTAF? All right. Okay. The evidence was well summarized. So actually, I'm going to make one quick process note. It's fine on this one for sure. But as we move from question to question, if you can try to hold your votes, even if you're 1,000% sure you know which way you're going to vote, if you can hold it until I kind of ask you to vote, because that way we make sure that you get a chance to benefit from any comments that are made among you or the panel here. Okay, so please go ahead and complete your voting, though, on this question. For chronic migraine, is the evidence adequate to distinguish among the CGRPs? We have 12, right, Matt? 12? 13. Okay. With that, let me show you the results. I think I'm going to have to do what you said, which was... I did already once. No, it didn't pop up.
Go back.
There we go.
That's voting questions.
Oh.
Question 2 is...
There it is. Okay. Good, you guys, good. You can see the results there. So the results are 12 no, and 1 yes. Sometimes, but not always, we kind of break it down after the vote just to see if we want to understand the thinking of any differences, thinking behind any differences in the voting. With the person who voted yes, if you want to, would you like to suggest why you thought the evidence was adequate?
This is Bill Remack. I voted yes because there was evidence that the CGRPs actually reduced the number of episodes a person had per month. And even though, as a comment, I couldn't see a direct correlation with that and the other medications, there was a patient benefit. And I felt it was adequate enough that we should look at that further and give that the benefit of the doubt.
Okay, just so you know, this question was whether you could distinguish between the CGRPs, not whether the CGRPs are better than other treatments or no treatment.
Oh, I see.
Those votes are coming up. So
Okay.
with that caveat, would you have wanted to
I'll,
amend your vote?
yes, I
perhaps?
will. I'm sorry.
All
Okay.
right.
Thank you.
Okay. That's why we do this sometimes.
Yes. All right.
All right, so the record will note that with clarification, it was
All right.
13 no and 0 yes.
Okay. Thank you.
All right, question 2, still in the patient population with chronic migraine. Is the evidence adequate to distinguish the net health benefit between treatment with CGRP inhibitors? Now that we've determined that we can't distinguish among them, we can think of them as a class, if you will. So we're going to ask you whether is the evidence adequate to distinguish the net health benefit between treatment with CGRP inhibitors and oral preventive therapies. Here again, we're kind of treating them, not kind of, we are treating them as a set. So we are leveraging the findings in the report that did show that all of the results on their effectiveness was in the same range, the amitriptyline, topiramate, and propranolol on an average basis. So again, this is at averages, but is the evidence adequate to distinguish the net health benefit of CGRPs versus other oral preventive therapies? Alex, again, which tables and just a brief statement about what we said in the report?
Sure, so it'll be the same pages and the same tables as the previous question. So page 3 and 4 for the efficacy, and page 11 to 12 for the harms. And here we rated the evidence as inadequate because we saw a similar magnitude of benefits in terms of the clinical efficacy for these interventions. There were fewer adverse events that we saw in the short-term trials, but there's considerable uncertainty in terms of the longer-term side effects and potential adverse events with the CGRP inhibitors.
Okay. So this is not about just patients who failed other treatments. This is about, in a sense, all comers. Is the evidence adequate to distinguish between CGRPs and other oral preventatives? Any questions from the CTAF? Okay, Alex, I'll get started again with a question. Again, this is partly about the patient eligibility for those older trials. At least most of them will be older on amitriptyline, propranolol, topiramate. Some of the features of the CGRP studies, including, especially for chronic migraine, the fact that they had to be adherent to a headache diary. There was a washout phase for some of them. Can you comment on whether any of those aspects of the trial design would be thought have been, could have biased, if you will, or slanted or tilted the results in one direction or another between the CGRPs and the other drugs?
Sure, yeah. So as Steve commented, there are some inclusion and exclusion criteria that were a bit different and some general study design characteristics that were a bit different with the CGRP inhibitor trials, notably, excuse me, the baseline and run-in phase in which patients were required to comply with a headache diary. So patients that did not have 80% or higher compliance were excluded from the trials. So to the extent that these patients are different than the types of patients that you see in clinical practice, you may expect a different results for the wider population.
Okay. Clinical experts, anything you'd like to comment on here on the evidence? All right. And sorry, I should have asked, but I think this is in the material, but the ICER evidence rating that we gave to this judgment was?
It was insufficient. Yep.
All right. It would be great to be able to compare the studies head-to-head in a way, and we'll talk about future research, in which the patient selection is a little bit closer to the kind of similar across studies, especially within a class. It makes it hard when it's not, but it's just something we always think about. Okay. No questions from the panel? Then please go ahead and vote. Is the evidence adequate to distinguish CGRPs versus these other treatments? Let me see if I can get this to work right the first time. There we go. Okay. 100% no. There's a way to make that. I know how to do it, believe it or not. I think this is it. There we go. 12 no. Bless you. Okay. Heading into the third question then. Still with chronic migraine. Is the evidence adequate to distinguish the net health benefit between treatment with the new CGRPs and Botox? Alex, over to you again.
Yep, so it'll be the same tables on page 3 and 4 for efficacy and 11 and 12 for, harms. And for this rating, we also rated evidence as insufficient, again, weighing the uncertainties with the potential for longer-term prolonged use of the CGRP inhibitors and looking at durability of efficacy and potential adverse events in the long term.
All right. Anything about the studies that are germane to the judgment here that you can think of? Again, about patient selection. I mean, obviously, chronic migraine is already, it is defined as it is, but do we think that the patients in the CGRP studies were similar or different to the ones in the Botox studies?
They were fairly similar in terms of the baseline characteristics. So I think Botox studies had 19 days in terms of migraine days per month at baseline, and the CGRP inhibitors had about 17 or 18. So it's slightly higher, but fairly similar.
All right. CTAF, you're finding this way too easy. Yes. Sorry, can you use your microphone to make sure people can hear?
My apologies if this is going to take us back a little bit, but I was wondering about if the first question about the way that it's phrased, is the evidence adequate to distinguish whether these three medications are similar? It seems like there's much more data for 2 versus the third. And the way that the question is asked, it's like, is the evidence adequate? I would say no, but that does not necessarily make me feel comfortable saying that all 3 should be classified as a group and thought in the same way. And because for all of these questions about chronic migraine, there are no studies for the third one, galcanezumab, whereas there are data for the first 2. So I'm not quite sure how, I wouldn't change any of the way that I voted, but I'm not quite sure I feel comfortable in saying that the votes that I'm making should apply to that third drug that we actually don't have any data for in chronic migraine.
Thank you. It's your first CTAF meeting, and you've hit on one of the core things that we have wrestled with through the years. The way we handle that, so you're absolutely right. When we say, is the evidence adequate to distinguish, you could say no because there's never been a study, and so I don't know, or you could say no because there have been good studies, and I know that they're essentially the same. So we make a notation about this feature, and we're complicating it because there is one of the 3 for which there is less evidence. So what I will say is that we will notate this issue and that we'll make sure that it's clear, although the evidence base is evolving on all the CGRPs, clearly for galcanezumab, there's further kind of work that was not included in the core results of the paper yet. We will weave that into the final evidence report in terms of that new evidence, but also we'll make sure that the votes reflect the comment that you just made. Alex?
You just commented a little while ago that it'll be nice when studies have similar baseline recruit patients with similar baseline characteristics. It will also be nice when studies are head-to-head comparators between treatments.
Right. We know that we almost never see that at nearer at or near the time of FDA launch, but it sure opens up the possibilities for other entities or clinical researchers, manufacturers themselves to go there, and we hope they will. We'll come back to that in the policy roundtable too. Other questions or comments? Again, we're going to talk about the clinical issues of Botox versus this when we get to the policy roundtable, but based on the evidence, does the panel have any other questions or things you'd like to ask the ICER team or the other experts? Okay, please go ahead and vote. All right, this time I will wait till 13. I did it again. Darn it. Help me, Matt. Because sometimes it doesn't want to go back. That time it advanced just when I hit this. There we go. 12. All right, that's the 13. Okay. All right. I'm sure there was a lot of suspense around that answer. There you go, 13-0. Okay? Now, the fourth question requires you to think about a different group of patients. We're still with chronic migraine, but now for patients who have no other options for preventive therapy. Now, that by itself is a little hard to understand. Does that mean that they've tried everything? Everything of the 3 that we've focused on, the 20 other drugs that have been potentially used off-label every once in a while? It really is intended to mean patients who have tried and not gotten adequate success from the other preventive options. And so they're really faced with a question of using a CGRP or no change to their therapy. So it's really kind of CGRP versus nothing different for those patients who really have no other good options, you could say, perhaps, for preventive therapy. So here again, the question is the evidence adequate to demonstrate a net health benefit for the CGRPs in that clinical situation? Alex, and then I'll give Kevin a chance too. Alex, please.
Sure. So this will be on page 13 in table 4.4, and I just want to remind the panel that these data are confidential data. And so in terms of the evidence rating, we rated this as comparable or better, so a C+ rating. And the rationale for that was, though, there are still the uncertainties with the longer-term effects or adverse events. We felt that for this particular subpopulation, that the benefits may outweigh those risks.
Okay. So C+, right, Alex? Sorry? C+. And again, we've talked about this within the CTAF panel, and this is part of our struggle to do this right, but we're in a public meeting where we're talking about confidential data. So the panel is going to be voting on something that they can't literally say the exact number out loud, but they can talk about directionality. They can obviously get a gestalt of how things compare. And I'll give them some time to do that because you really do have to kind of work through the different weak findings between different drugs. So let me ask, yes, first, yeah, go ahead.
This is a question for Alex. I was wondering how well the population described in the question matches the population of the studies. So specifically, the thing that I'm concerned about is if there are people in the studies who do not actually exactly match the population, the summary population effects from the study may suggest benefit, but the specific subpopulation that we're talking about in the question may not actually achieve that same benefit.
Sure. So this data that you're looking at comes from this subgroup for whom existing therapies have failed. And in these trials, they had inclusion criteria that allowed patients up to, I believe, 3 prior failures. So we're looking at the subgroup for 1 to 3 prior failures in this example.
So, but your question's a good one because it's not a perfect fit. So some of the patients will have failed 1 treatment, but have obviously at least 1 or 2 more they could try perhaps. The trials excluded, I thought it said it was actually no more than 2, so at least the chronic.
Some trials are 2 and some are 3.
Some 2 or 3, okay. So it's a bit of a mix, and it doesn't mean that every single one of those patients had no other options. But we are trying to frame, in a sense, this for the clinical situation, and certainly this is headed towards a potential value situation when it is viewed for the patient that there are no other options of preventive therapy. Yes, Alex?
I'm struggling with this question because I think I can say in general that this confidential table suggests that for patients who have tried 1 to 3 prior medications that have been unsuccessful, these medications are effective, at least as effective as they are in the whole group. On the other hand, we don't know much about patients. We don't know anything about patients who have tried 4 or more previous therapies. And I tried to Google earlier, on average, how many medications, how many preventive medications have persons with migraine tried? And I couldn't find an answer, but I suspect it's probably more like 4, 5, 6 than it is like 1, 2, 3, right? Yeah. Right. Right. So we have no data. It's a data-free zone. That's a big part of my struggle, and we have no long-term data about harms, which is a major concern.
This isn't a good answer to your question, but I'll invite Alex to comment on generally how the effectiveness of these drugs are within this subpopulation versus the entire population. So if you started to see a strong trend one way or the other or no difference, it might help inform your thinking a little bit. Alex?
Yeah, and Alex had mentioned this as well. There's generally, we see a slightly larger effect in this subgroup. Of course, there are limited data. These data come from one trial for each of the drugs. So yes, more data would be helpful to inform those estimates.
Yeah. And I guess, again, in terms of the codicils we can put with the results of the votes, we can make it clear that the panel acknowledged or raised the issue that there are no data for patients who have failed 3 or more preventive therapies. So I should say more than 3, since there's at least one of the studies that does. So that, again, there's a kind of the studies represent a certain part of that spectrum, and we are asking you to generalize a little bit given the language here. So I'm not sure I'm helping that much. Jeff and then Joy.
Yeah.
Can you make sure you use the microphone?
If it's okay, I'll respond a little bit.
Oh, sure.
I have treated a few headache patients in the years, like a lot. I think that you get to an interesting point, but I'm not sure. The problem is the population. So folks that are desperate and have tried everything may have been through multiple medications. There's actually a fair number of people that are successfully treated. It turns out only 10% of migraine patients ever make it to neurology, is what our data suggests, which is that preventative medicines do have a role. The population we're looking at is the ones where they haven't been effective. And so it really does get to your point, which is this really comparable or not? And the answer is we really don't know, because there are people that have been through everything. And, I get to the point where I'm not sure anything I can do is going to help. Sometimes Botox in those patients is a godsend, but sometimes not. But then there's a fair number that will respond. And so it is kind of a difference. You may have somebody that didn't tolerate their first few medications from side effects, but will respond, or you may have somebody that has been through 6 or 8 different drugs. You're right, it's hard to know the answer. So this is what medicine is all about: vague, imprecise, dirty, real world sort of stuff. So it's not it's not. It's kind of like the MS clinic patients. They all look horrible, but the ones that get treated before they get to MS clinic may do pretty well because there's a difference. So I think you need to keep that in mind, that there probably is a little bit more complexity here than you can just get based on the way the studies have been done. You'd have to specifically design that study, and that kind of group was sort of excluded.
Yeah, thank you. Joy, I had forgotten that Kevin had his up for a while. Can I let Kevin go first? I forgot that he's been waiting for a while.
So I'm concerned about the wording of this question. I think it has meaningful impacts for how it will be interpreted by other stakeholders. in the sense that when you say who have no other options, that can lead to an assumption that everything has been tried and exhausted, and anticipating next steps and step therapy that may be applied here that assumes or it implies a very high threshold there. Whereas I think the studies that we're looking at here said that there had to be at least one failure, the 1 to 3 preventives that they had tried. So I think a better phrasing for this question that would be more accurate to the data on which it's based and represents would be for patients who have been failed by one or other preventive therapies, ... I think that's just much more accurate and it will have a better interpretation by others.
A friendly amendment is that part of the issue here is if there is another treatment option, let's just say amitriptyline, the value, if we're headed towards value based out of that wording, would be very poor because the patient should try amitriptyline from a value perspective. So what we were trying to do is to build the best case, honestly, for the value to be looked at as CGRP versus there's really nothing else to which to compare it, because all the findings suggest that if there is an amitriptyline or a propranolol still in your toolkit, that the value of CGRPs through cost effectiveness would be quite poor. So does that make sense? We were actually trying to create the better framing or a different framing that would allow us to compare CGRPs to no therapy.
Right.
And we will, what your point though, I'm not saying it's not well taken, because the whole question of how many drugs would have to be tried, what does a trial mean, and all that kind of stuff is going to be the meat and potatoes of the policy roundtable.
Right, and I don't think anyone can define how many preventives there are in total. It does imply that you need to go through all of them, and you can't even tell me how many there are.
No, so don't, right, so don't.
We're not in the cost effectiveness, I understand, it's the clinical.
Right.
And clinically, I think the data is based on having at least been failed by one preventive. So that seems most accurate to what we're basing this on.
Yeah, so if you can hold both thoughts in your mind that we're creating a pathway for talking about the effectiveness and the value when there are no other options available to the patient, for whatever reason that might be clinically. Joy?
So now I have a comment and a question because you've put me off, so now let me to a comment. So the comment is that I have similar qualms about the wording, because although as a practicing physician, there are a whole lot of things I do where I have to make a choice and I don't think the evidence is adequate. That's not what this question is asking. It's not what would I do in the office with a patient in this situation. It's, is the evidence adequate to demonstrate a net health benefit? And that's a different question than, you know, would it make sense for people who had no other options to try this, is not the same as, is there adequate evidence for a net health benefit? So that's my comment. And then I have a question which relates to the fact that I've been getting in trouble for reading ahead since I was in the 5th grade. So I'm wondering, Alex, if you could explain a little bit more how the evidence report came down differently, I think, on this question for episodic migraine than chronic migraine, because when I look at the tables, I'm not discerning anything that would lead me to a different conclusion.
Sure. So the rationale really is that because the chronic population is slightly more severe than the episodic population, we felt that the weighing the benefits was slightly higher for this population compared with the risks. Whereas for episodic, they were similar, but we did weigh the benefits a bit more. But because this population is more severe, we weighed the benefits higher.
Right, remembering that net health benefit includes the weighing of the potential risks given the limited data on harms. So I think what Alex said was
But then
was
the
exactly
definition that divides these two groups is a little fuzzy too, right? So we're talking about 15 or more days versus up to 14 days.
Right,
So.
right, with that magic line at 14 3/4, absolutely. Any other questions or comments? I think this has been a good discussion on this one. Okay, please go ahead and vote. A is yes, B is no for adequate evidence to demonstrate a net health benefit for CGRPs versus no treatment for patients who have no options for preventive therapy. I'm waiting. I see.
Kicked me out. It kicked me out. Okay, I'm good. Wait. Okay, good.
All right, thank you. Let's see if I can, am I going to get lucky on this one? There we go. All right, and for real-world numbers, that is 10 yes and 3 no. Okay, maybe real briefly, just look careful of the time. Someone who voted no, if they would like to describe why they voted no? Sorry, Kim.
Yeah, I'm very appreciative of the evidence review. I put it as a PI and not a C+ in my mind.
Because?
Well, because when you look at the number, it's we're talking about very subtle, no, not subtle. The differences were consistent and across all trials in terms of the net improvement, and yet for this one question, they totally changed their rating, and I thought that was interesting.
Okay. Anybody else? I think we heard, yes, Alex?
I voted no for the reasons stated before that. I think that most of the patients who have no other options for preventive therapy have tried more than 3 preventive therapies, and we have 0 data on that. I'm not comfortable with the extrapolation.
Okay. So again, it will be noted that a no here does not mean a presumption of similarity. It just means that we don't have data based on the patients, this patient population. Okay, good. Let me keep going then. Thank you. So now we're shifting to where Joy was reading ahead. All right. So episodic is kind of a quixotic term. It just happens to be those with less than 15. But this is the episodic kind of subpopulation. So for these patients, is the evidence adequate to distinguish the net health benefits among, here it says among, the CGRP inhibitors, iranemab, fremanezumab, and galcanezumab? So we've talked about the wording, the lumping. Alex, again, can you remind us of the rating, the rationale, and the tables they should look at?
Sure. So the evidence is on page 5 through 10 in terms of efficacy, and then pages 11 to 12 for harms. And so here, for the same rationale as in the chronic migraine population, we rated this comparison as insufficient at this time.
Okay. I think we may well have covered any issues related to distinguishing among them at the earlier vote and discussion. So unless I see a question or a comment about this one, okay, please go ahead and vote. Distinguishing among for the episodic population. There we go. All right, let's see if I can get it there. There we go. Okay. 12 no and 1 yes. Just because of time, I'm going to go forward without a kind of debrief on that one. So let's go to the next question, which is question 6. Again, episodic migraine population, is the evidence adequate here to distinguish the net health benefit between treatment with CGRPs and oral preventive therapies? Alex?
Yep, so it'll be the same pages, 6 to 10 for efficacy and 11 to 12 for harms. And for the same rationale as in the chronic migraine population, we rated this evidence as insufficient.
So no head-to-head trials, just again, big picture, obviously. Confidence intervals widely overlapping. Okay. Any questions? Okay, please go ahead and vote on this one. Just noting we've already inflicted 78 PowerPoint slides on you today. That is yeoman's work. Okay. All right, so it's 13 no, 0 yes. All right, question 7. All right, so here we're back to that other issue again for the patients who have no other options for preventive therapy and have episodic migraine. What here do you think about the evidence? Is it adequate to demonstrate a net health benefit for CGRPs versus no treatment? So Alex, the rating here was different than the rating given to chronic. You answered that when Joy asked her question, but why don't you just repeat the thinking behind that?
Sure, yeah. So we rated the evidence as promising but inconclusive, again, weighing the potential benefits more than the potential harms for this population. And in terms of the tables for this evidence, it's on page 13, table 4.5. And again, this data is confidential.
Okay, again, I know a lot of the, Alex, you look quizzy, you look unsure.
Oh, never mind.
Okay. I was about to say, all the comments that were made about this question around the chronic apply equally. The shift, at least in the ICER rating, as Alex said, was due to a judgment that the clinical benefit was not as great as on average as for patients with chronic migraine, and the same questions remained about longer-term durability and also harms. So it shifted from a C+ to a promising but inconclusive. All right. Any questions? Any additional thought on this one? Anybody thinking of not voting the same way on this one as they did on chronic? Want to explain why before we have the vote? See if you can convince somebody else or elucidate your own thinking. Say.
I vote. I am worried about the unknown long-term toxicity data, and I think Alex's thinking is spot on. That given the lower average burden of disease in this population, the net harms may outweigh the net benefits.
Anybody want to? Kevin, I'll give you the first shot this time.
Great. So I do want to point out that there's a lot of variation in this population. One of the requests we had made was to further break out a sub-evaluation of the medium and high-frequency episodic migraine patients. The data that we have shows that those who are experiencing 10 to 14 headache days per month are much more similar to the amount of disability that they experience in their lives, similar to those chronic patients and dissimilar to others in this episodic category. So it's unfair from our perspective that they're all being lumped together, and I just want to correct that from our perspective, there is a tremendous amount of disability that still happens, and I think if you asked many of those patients, especially at the upper end of this, if they were willing to take the risks that the panel had largely said that they were comfortable accepting for the chronic patients, I think a lot of patients in this group would be comfortable with those unknown risks as well.
Thank you. I'm going to go to Jeff, but just real quickly, Alex, can you remind us what was the mean number of migraine days in the episodic trials?
At baseline, I believe is around 8.
Baseline, 8. Okay. So interesting. All right, Jeff.
Yeah, and I'd agree. I don't think all migraine patients are the same. Some people have lots of headaches but muddle through. There's other people that show up in the ER twice a month. So it's not all uniform, and I think that's your point. And it's not just frequency, it's also severity. So it's a mixed bag again.
Yeah. I'm really looking forward to the policy roundtable where we talk more about how to define. What's tough is that it's still going to be defined on averages, but what we're talking about is how diverse the experience is, and even with the same number of migraine days, how different the level of disability can be, right? Okay, good, we'll get there. All right, any other questions or comments? Okay, please go ahead and vote. Yes or no, CGRPs versus no treatment for those who have no other options. All right. Okay, 9 no and 4 yes. What was the results for chronic? Was it like more yes than no? 10 yes, 3 no. Okay, interesting. So I heard from Say's description why I could imagine some of you changing your vote from yes to no on this one. Are there other comments? Because I think this is one of the more important votes to elucidate and make sure that we kind of reflect correctly what people's thoughts about the evidence were. So anybody else who I guess the more important or interesting is flipping their vote from yes on chronic to no for episodic. Anything you would say that hasn't already been said, or was it all that, Mike?
It's kind of been said, but this goes to trial design and the questions being asked. I have a lot of, I'm not in this specialty, but I have a lot of problems with what you were just saying, you know, number of days versus severity, because if you ever had a real bad one, and I have, it can lay up for 2 days, but I don't get them again for another year, you know, so they're not asking the question in a way to get to that point, is the evidence adequate? They're just not studying the right thing.
Okay. But would it be fair for those of you who voted no and voted yes, especially those who voted yes on the other one, that the dominant reason of changing the vote was related to this perceived change in the benefit with the same kind of uncertainty and harm potential? Is that mainly what was driving people? If not, speak up, because that's kind of, I think, what we want to capture. Okay. All right, thank you. We are now going to move on to something very different, but very important. If you remember the ICER value framework, and when we talked about potential other benefits and contextual considerations, here's where we get to talk more about that and vote on them. So here again, we're going to be talking for these votes about the patients who have tried other preventive treatments and have, those treatments have failed them. We're asking multiple different potential other benefits, and there could be others. So here's the ones that we talk about. First off, does treating patients who have tried and failed other treatment options, does treating them with CGRPs offer one or more of the other of these potentially, following potential other benefits? Reduced complexity of care with treatment options. Does it potentially reduce important health disparities? Reduce caregiver or family burden? Does it represent a novel mechanism of action or approach that could allow the successful treatment of patients who have failed other options? Is there a significant impact on improving return to work and overall productivity? And then F, other important benefits or disadvantages not listed here. One quick comment from me about E, which is a significant impact on return to work. So, as was described to you, the ICER base case, as it's called in the jargon, does not include the economic effects on worker productivity as part of the cost effectiveness, but we quite frequently do a model that does include that so that we can get a feeling for how much it might affect the cost effectiveness. So this is a chance for that information to inform your vote on number E, because you do have at least that if you will, empiric estimate of the impact on worker and overall productivity, but there may be other ways to think about that as well. So with that, I would like to invite our patient representatives, because this is where from day one, we seek input from many people, but you may have, obviously, a special insight into these potential other benefits. Would you like to comment on some of these? Yes.
I would like to add that it's not just the frequency and severity and duration, it's the disability that comes with migraine. And the cognitive difficulties that come with migraine create presenteeism. But what this question is failing to ask is how it affects family life and the ability for a family member to participate financially in the family. So I think you need to consider those things as well.
That should be actually under number C, where it says reduce family burden. You could consider that certainly part of that. Do you know of any data on family burden of patients with migraine? Do you have any sense for?
No, everything that I have in my brain is really anecdotal, yeah.
Okay, just curious. Kevin, anything?
I just want to pause for a second and just go back. I know, I won't belabor it, but just a little frustration with the last vote that we had with it. Really, it seems like a fear, and I understand we want long-term data about safety as well, but a fear of that held you back in what I felt was like a paternalistic way from allowing those who are episodic and want access to these medicines. And I want to call that out and let you know that I'm disappointed, and I think I speak for the patient community on that. And I just wanted the record to reflect that before we moved on.
Sure.
Thank you. That said, on this question, I think you have captured many of the elements that do impact people's lives, and I think it's an important vote to have on each of these.
Okay, clinical experts, do you have any thoughts yourselves on these potential other benefits that you think you'd like to comment on?
I think they do. They capture sort of a lot of the lived experience with migraine, particularly people who have that significant impact on their lives and who haven't responded before.
Okay. By the way, I know I'm up here, but feel free to respond. It's
a good list.
Yeah, I'm really glad that this question is on there because, practically speaking, we're not just reducing number of days, we're trying to improve quality of life and the psychological, social, it's just really multifaceted. So it's not just number of migraine days reduced, that kind of thing, but it's really, really quality of life for the person individually. So, yeah.
Can you comment on the reduced complexity? To be honest, that question is usually there when we're trying to consider whether to give extra credit, if you will, to a pill instead of an IV. Because it might have the same clinical effectiveness, but boy, patients would much rather have a pill than an IV. Is there anything here around the introduction of these treatments that represent, again, there's no IV version of CGRPs. We'll get there. When there's a pill version, we'll probably be saying, do we want to give it some extra credit versus the injectable kind? But is there any other impact that you imagine on the overall complexity of care that would be greatly changed? It might make them less sick, and so they're going to have less of everything. But is there anything else about the complexity of having, for instance, these patients haven't ever injected anything as part of their other treatment options, so does it increase complexity?
Can we correct that?
Oh,
I
sure.
disagree with that. With people who have been early users of triptans, they've been injecting themselves with triptan. And then for people who have more severe cases of migraine, they also use other injectables. For example, I use an NSAID that is injectable. So, and then I also want to bring up that the complexity of the disease versus the complexity of the injectable is, I think people will figure it out. Furthermore, people who have long-term diseases like diabetes figure out how to give themselves an injection. I don't foresee giving yourself a monthly injection as being an issue.
It's interesting because, when I saw that question, reduce complexity, I immediately jumped to, oh my gosh, once a month injection is so much easier than a daily pill. But actually, for some people, it actually isn't. And so there's some patients who don't want to give an injection. In fact, there's one interesting study looking at patient preferences where patients said they preferred a daily pill to an injectable, but they didn't break it down. Was it everyday injection or the frequency? Right. The other thing is to remember once a month. So that actually raises its own, outside of a clinical trial, to do it once a month is, has its own sense, especially, it also comes to health literacy. So it may seem that, the injectables are sort of straightforward. I have a bunch of patients who would never use the injectable Imitrex, and to explain it to patients who don't understand things, the literature is full of, you have a person for diabetes practice in an orange, and then they go home and they inject their oranges at home with the insulin. It's a very complicated process. I took a look at the patient's insert. It's not as easy as the sumatriptan injection. It's a little bit more complicated. So I think it really is in the eye of the beholder. To me, I was like, oh, this is so much easier, and maybe it is for a group, but I don't think it will be for everyone.
Right. I'm a nurse, and so that's the way I'm looking at it.
I also want to add that I think that if the patient is suffering migraines that are so debilitating, they will figure it out. People are willing to sit through 31 injections of both. People, are willing to sit through 31 injections of the Botox treatment every 3 months. That's not pleasant, but they will tell me, I hate this, I hate you right now, but it really works, so I'm going to do it. And so it's that one moment per month, I guess it's up to the patient.
Yeah.
All right, thank you. So, say, yes.
I'm trying to figure out, it seems like many of these things we are considering as a kind of a function of the disease as opposed to the drug. So it seems like in terms of reducing caregiver and family burden, in terms of significant impact on improving and returning the work and overall productivity, that is the effects of this drug on those outcomes is all mediated through the efficacy, in terms of the efficacy. And so it feels a little bit odd to me. Are we giving double credit for these things by saying that it's also having these effects? I can understand reducing complexity if the specific drug is easier to take and that we actually talk about it in terms of that drug. But for some of these other, so I want to clarify kind of, are we talking about a drug effect versus a disease modifying effect?
To be honest, it can be both. I think it's more important for us to be comprehensive than to worry about double counting to a certain extent. The other reason that some of these things are here is because we may feel like we've captured it clinically, like reducing caregiver burden. We might say we've captured that by talking about decreasing migraine days. But when you go to thinking about what was in the economic model, maybe it hasn't been directly modeled. And so this is the opportunity to think about whether there was an economic aspect of that hasn't been fully appreciated. So it's a little bit of both, but I would encourage you to not worry to a certain extent about double counting, because it's just to make sure that we are comprehensive, because what we want is for policymakers viewing the report to think broadly about value, as we'll encourage you to when you take your vote. So I'm also sensitive to the time that I have to be the manager of. So I think I'm not seeing any other tents up. Why don't we go ahead and vote? Now again, on this one, you vote for all that apply. So you can A, B, C, D, or E at this point, since there were no Fs introduced. And will I still know that it's 13? Is that what I'm going to know? Okay, in this case, just to be triply sure of the mechanics, that's right. If you enter a single vote, it will register here. So I just need to know when people are still entering. I'm going to be looking at you guys, actually. So when you're done, just put your phone down. Has everybody finished their voting? No, Kim hasn't? Okay. Is anybody else still voting? Raise your hand.
We can check as many as we want, is that correct?
Correct, all that apply. So we're, I think, waiting for Kim. It's interesting that we have 14.
Okay.
Okay. Let's see if this works again. I already did. So we'll try it one more time. There we go. Good. I hope it doesn't move. Okay. Yeah, all right, thank you. So let's take a look here. All right, 4 out of 13, reduced complexity. 2, reduce important health disparities. 12, I don't know how we got 14, whatever the third one is. Reduce caregiver family burden. Novel mechanism of action or approach. Significant impact on improving work. And looks like 3 people thought they were thinking of something else, even though we didn't talk about it. So that's helpful. So again, 4, 2, 12, 14, and 13. All right, moving forward to what we call contextual considerations. This loosely fits with what some people consider to be the kind of ethical or social values that we attach to certain situations, such as conditions perhaps that are particularly severe, that have a lifetime burden of illness as opposed to a relatively short number of years that people are stricken with it. Whether the treatment is an innovation that is the first to offer any treatment at all. For instance, for a rare genetic disease, it might be the first ever treatment that we've ever had. And we also try to capture whether there's always some uncertainty, but compared to the comparator, is there a significant uncertainty about the long-term risk of serious side effects or about the magnitude or the durability of the benefits. So again, some of these feel kind of squishy, but they're meant to be viewed as kind of a comprehensive catchment of some of the important contextual issues that many people feel are important to keep in mind when you're making ultimate judgments about the value of some new treatment. Patient representatives, I hope you've seen this list before. It's good. Anything you'd like to add as something that you think the panel should think about?
I think some of the benefits that I understand the data didn't always justify, that just didn't exist yet or wasn't robust enough, but around these medicines likely or potentially likely reducing comorbidities, which is a very significant thing, and I think that will be a tremendous benefit, and I look forward to real-world ongoing studies that are hopefully able to demonstrate will capture more of that value moving forward. It is something really major, and we've talked about the opioid crisis that this country is having, and if we are able to have something that is effectively treating migraine and that is keeping people from continuing use of opioids or having a first-time exposure, and we all know that there's some percentage that goes on to have substance abuse issues, there are tremendous benefits there. And so these are some benefits that weren't able to be properly modeled in yet, but I look forward to data documenting those moving forward, and I think we'll see a tremendous value from those.
Thanks. Kevin, I wonder if you'd accept a friendly amendment, which is we didn't talk about that as part of the potential other benefits. You know, there was an F for adding in something else. And I don't want to go back and have a formal vote on it, but this is something that ICER in an earlier report, as you or somebody else commented, we're very aware of the risk to patients with migraines who come to the emergency room and are treated with opioids. So I think that the potential, without data, but the potential that this could offer additional treatment options that would reduce the need for opioids or the interest in opioids, friendly amendment would be to include that in the potential other benefits. Okay. Fair? Okay. Any other thoughts about the contextual aspects of this that the panel would like to raise to get input either from the clinical experts or patients or the ICER team?
Steve?
Yes.
I was wondering if I could ask, on that point of our clinical experts, we have a lot of trials of other migraine preventives and treatments. Have any of them ever shown reduction in migraine mortality increases or comorbidities? I'm just wondering if we can extrapolate from what we know of other treatments.
There may have been other trials which, monitored mood questionnaires and might have, shown some effect on mood, some effect on use of other medication, because those are outcomes that can be monitored. But I don't think that this is something that's systematically been studied. And I don't see why this medication would have any other more reduction in opiates than any other preventative medication, because what you're actually looking at is reduced severity of migraine. And when you have a reduced severity of migraine, you're going to need to use fewer medications. So I think that extrapolation, as much as if you knew my attitude about opiates and headaches, you would know my attitude about opiates and headaches. So I think that's going a little bit too far based on the data that we have, in particular because this is something that never would have actually been studied in other studies. And so when you make one class recommendation when and when it hasn't been looked at in other studies. And this is one of the problems with migraine. A lot of the things that we use were never studied to the point that they'd be acceptable today. And that's why we have so few options to compare medications with.
Good point. Sorry, it's a precedent that it's hard to do. All right, why don't we go ahead and vote then on the contextual considerations. Again, vote for all that apply. And the question is worded, are any of the following contextual considerations important, up to you to judge that, important in assessing CGRP's inhibitors' long-term value for money? And same thing, once we get to 13, I'll start to look to see if anyone's still working on it. Who's still entering? Anybody? Kim, are you still working?
Yeah.
Okay, is everybody done? Okay. All right, 22%, let me see what that is. Okay. So, condition of high severity, 11. Care of individuals with a condition of high lifetime burden, 9. First to offer any improvement, 1. Compared to comparator, there's a significant uncertainty about long-term risk, 11. Significant uncertainty about the magnitude of the durability of the long-term benefit. And I hesitate given the time. It sounds like some people may have thought there were other important contextual considerations. If anybody has one that's really easy and succinct, they think the report should capture, or maybe people just thought it was all of the above and voted for F anyway. Yes, Bill.
Yeah, well, I voted on the last one because for those that have exhausted everything else, this offers an opportunity.
Okay. So we could say, well, very roughly speaking, hope.
Yes.
Okay, thank you. We move to 2 final votes. I thought there would be applause for that. No? Okay, fine. Just 2 more votes. Just 2 more votes. Here's where it gets put together. So we're back to chronic migraine, adult patients. We're still with those for whom other treatments have failed. The question here is considering the comparative effectiveness, incremental cost effectiveness, considering the potential other benefits, disadvantages, and contextual considerations, what is the long-term value for money of treatment with Erenumab versus no treatment? Why Erenumab? Because that's the one for which we had a price. Okay, we assumed the same price to a certain extent, but we have Erenumab's price. We have its assumed discount, and that's the base case. So we're assuming a 27% discount off of the list price. And Alex, can you just tell them again where in the evidence summary tables they should find at least the cost effectiveness piece of this, now that we're going back to that?
Sure, I'll pass it on to Suri, actually.
Or Suri, I'm sorry. Suri, how about you, Suri?
It's all right.
You had a little role in that.
Really, it's 13 through 18, but it's kind of more summarized on 14 and 18 in terms of the numbers.
Right. And some of these tables, again, are bolded in red, which means that we're not supposed to talk about this very specific numbers, but the ones in green are fair game. So again, you can see, and just to very briefly review what the cost per qualities gained were in the base case, which is in table 4.15. Sorry, you go ahead if you want to. It's your work.
Sure, the base case again is on page 14, and there's
so we're on chronic migraine here.
you can see both in terms of, I would focus on the cost per quality column.
Right.
And then if you go to...
But I just want everybody to hear it again. It's $90,000 per quality for Erenumab.
Yep.
Okay.
That's the number we can speak about. And if you want to see some of the scenario analyses, if those are going to impact you, that's mostly summarized on page 18.
Right, okay. I hope you guys are finding that. If you are looking for something that you can't find, let us know. Okay, back to the CTAF panel. We've talked about the comparative clinical effectiveness, voted on it. We've talked about potential other benefits and contextual issues, voted on it. Now again, you're asked to, in a sense, put that together, and you're about to vote whether it's low value, intermediate value, or high value. Who would like to take a brief flyer and explain to us why they think they're about to vote one of these and give their thinking so that other people on the panel can hear and perhaps compare and contrast their own thinking? Does anybody feel confident that they know what they're going to vote on this and would like to suggest? Jeff?
Well, I'm basically a cheap kind of guy, but even so, it fits into our framework and the generally accepted cost effectiveness. And then if you look at the other contextual considerations, I'm willing to give it extra credit. So I'm actually going to vote high on this, which is pretty unprecedented for me, being how cheap I am.
Well, now you've set a difficult bar if anybody wants to vote something else. But anybody? Pat?
I tempered that high a little bit and selected intermediate because of the safety concerns for the long term.
Rob?
Ditto.
Okay. Anybody else want to weigh in with something that's factoring heavily in their minds, either a particular potential other benefit or the overall cost effectiveness or something like this around the uncertainty? Mike?
I brought it up earlier. I'm going to vote intermediate because I think it works, but it doesn't work in a defined or a majority population. In fact, it's getting fairly well defined, and so that kind of brings it down in my vote.
Okay. Any other comments people would like to make before the vote, which thank you for holding off so that you could hear your colleagues' votes. Okay.
Can I comment before we?
Oh, sure, please go ahead.
Right. I just wanted to say that going to your comment about hope, that this is fundamentally about a population defined by the question who have been failed by other treatments, who are enduring pain at high levels and frequency more than half of their lives if they're a chronic migraine patient, who are suffering and the disability that comes with that. And the model, the base model that we're using here is from the payer perspective. It doesn't factor in so many other costs that are associated with this, the societal burden, the impact on so many things. So I just want to sort of make the plea that when seen in totality, and for this population, I even will carry this comment through to the next question as well. But this is a group of people who have been failed, they're struggling, they're in pain, and they need hope, and you have that opportunity.
And just to read ahead like Joy likes to do, this is the chronic question. There'll be an episodic question in about 60 seconds. Okay, let's go ahead and vote then. A, low value, B, intermediate, C, high. Please carefully select so that you don't accidentally pick the wrong one. Okay. All right, quick change, as I said. All right, let me press this first. So, all right. Interesting. I thought somebody else said they were going to vote high. No? Okay. Jeff, so you were the high. We know that in this confidential voting system. All right. So thank you. So I don't have to do too many debriefs on the intermediates. We've had some of those comments. All right. So now we are going to move to the last voting question, which is for episodic, fewer than 14. Again, a greatly diverse, I'll point it out because I know it's important for people to think about the diversity of this population. They're not monolithic, but here, given the available evidence, again, on the different parts, comparative effectiveness, incremental cost effectiveness, potential other benefits, disadvantages, and context, what's the long-term value? For money of Arenumab, and again, sorry, just to point again to the cost per qualities on this as a piece, where can they find that?
Page 14. where for episodic, the number we talk about is $150,000 per QALY. There's also some of the scenario analyses summarized on 17 and 18. Page 17 and page 18.
Right.
What are those numbers for the scenario analyses?
The
You can share.
the scenario analyses that I can share. So if you count the productivity effects, it's $110,000 per QALY.
Right. So the base case is 150,000 per QALY. The modified societal perspective is 110. That's probably, as you said, that's the one I thought you were going to ask about. So any other thoughts? And here again, it's especially interesting to hear people's thinking if they're going to vote a different value vote on this one as opposed to the last one, what their rationale might be. Help your colleagues think about it. Jeff, I'm not going to ask you how you're going to vote because we'll know one way or the other perhaps. Anybody want to ask any particular or present any particular arguments for this vote as opposed to the last one? Sure, Jill. I'm sorry, I didn't see your card up. Go ahead.
I'd like to remind you that even though a person is episodic, and we've already talked about this, the frequency of episodic migraine still could be up to 14 migraine or headache days per month. It's still debilitating and somewhat demoralizing when you feel like you are an unreliable friend, wife, mother, employee, because you never know when the next migraine's going to hit. Am I going to be out of commission for the next 3 days, which is what happens to me when I have a migraine attack. So I don't feel like a reliable friend, wife, mother, employee, because I never know when the next attack is going to come.
Okay, thanks. All right, we're a little bit behind schedule, but I think we've had a good conversation. Please complete your voting. A is low value, B is intermediate, C is high for arenyumab versus no treatment. All right, we could be done. Let me see. Of course we're done. Sorry, we don't have multiple votes. So let's see what the answer is. All right. I think they call that a close election in the Chicago sense here. 6 low value, 7 intermediate value. So there was a shift from intermediate into low. All right. Would people express that that shift was because of the shifting incremental cost effectiveness ratio? Was there something else about the potential other benefits or other things that influenced your thinking? Anybody want to venture a statement on what led them to change their vote? Maybe a little bit shy. Alex?
For me, it was it came back to the comparative clinical effectiveness, and that we don't have, that there's less potential for benefit in episodic and uncertainty, in the setting of uncertainty about long-term harms. I rated a low value.
Okay.
And I didn't change my vote, but I am concerned about the potential for overutilization or overuse in this population.
Say.
I wanted to echo that. I think clearly the patients that we've heard from, the patient advocates we heard from, I'm absolutely incredibly sympathetic to kind of the hope that this drug offers and the potential benefits. But again, if we go back to what happens with other medications, it's tested in a very severe disease population, and inevitably it gets broadened to use in a much wider population where, because their underlying risks are smaller, any potential harms then have a tendency to wash out those benefits. And so I am I'm generally supportive of kind of the very severe population having access to this treatment. But then when I think about the indication creep of seeing it in less and less severe patients, that's where I feel very nervous that the overall population-level harms of this drug are going to outweigh the population-level benefits.
All right, I feel an avalanche building to talk about these issues, and that's what our policy roundtable is going to do. So we are going to take a 5-minute break. I apologize for the short, but let me tempt you with what's on the other side of that. We're going to come back and we're going to build a prior authorization model for these drugs by insurance companies. We're going to talk about future research, what patient education should look like, and many other factors. So we'll come back in 5 minutes for the beginning of the policy roundtable.